Good afternoon. My name's Kim, and I'm introducing the next session. I am part of the planning committee for Mountain States, and I'm with the Utah Newborn Screening Program. So it's my pleasure to introduce the next speakers. It's a team of speakers. So it will be Dr. Stephen Kahler. He is professor of pediatrics at the professor in pediatrics, University of Kentucky. And then also Kristi Wees, who's the project manager with Mountain States, as well as family leader and an empowered parent. So they will be talking about autism and the MChat. Okay, go ahead, Dr. Kahler and Kristi. Thank you.
Thanks, Kim. I appreciate the introduction. Today, Dr. Kahler and I will be talking about beyond the MChat, autism as a systemic condition. We do not have any disclosures or conflicts of interest for either of us. And this is a little overview of our talk. I won't read it all to you, but we will be going into ASD presentation, medical comorbidities, and specialist referral and PCP support. Since this is in the outreach track, we are focusing our outreach to community medical providers, specifically pediatricians and primary care providers, and how they can help a family who has a child with autism. These are our learning objectives for today. Again, I won't read them all to you, but you will see these later on the evaluation. So please take note of those, and hopefully we will have answered them all by the end of the presentation. With that, I will turn it over to Dr. Kahler to tell us about A is for autism.
Thank you, Kristi. It's a pleasure to be here. I'm going to tell you a bit about my take on autism and the biochemical, metabolic, systemic aspects of autism that have been overlooked and underestimated for a long time. It is not just a behavioral or psychiatric problem, but that's the basket it started off in. The first thing is to talk about definitions. The DSM has got a series of definitions that have evolved over the years. So has the ICD codings. But they are typically based around social interactions, communications, restricted patterns of behavior, impairment in all of these areas, not doing well in school, not being able to make eye contact, a whole bunch of things that are separate from global developmental delay and intellectual disabilities. The next slide, please. One of the important things about this definition is that there's nothing biological about it. And there are known medical or genetic associations, Down syndrome, Williams syndrome, Fragile X syndrome. None of those guarantees a child will have autism. Lead poisoning could do it. PKU in the old days could do it. So there's nothing specific about autism. It's not guaranteed in any genetic setting or any other diagnostic category. And the symptoms, of course, are how it's diagnosed. And we're going to say a little bit about the MChat because that is one of the screening tests. The most important part about the definition of autism is there's nothing biological about it except the age of onset. Everything else is a phenomenon of how we view a child is interacting with us or with his parents and so on. Next slide, please. Okay, the MChat is a screening tool that is a questionnaire that's filled out by parents. There are other tools like that. Then there are more formal diagnostic tests administered by trained professionals such as the ADOS, where if you get enough points on those tests, you will be considered on the autism spectrum. And if it takes 30 points out of 45 to be called autism, what are you when you're 29? Well, you're not neurotypical, you're just not at 30 points. Another one would be the CARS rating scales. So there are various ways to try to quantify what is going on with a child who is on this spectrum. Next slide, please. Now, to me, autism presents in a couple of ways. One of them is a gradually emerging phenomenon of not so much communication from the child, not making eye contact, somehow not being right at the beginning, and we'll talk about that a little bit. And by the age of 2 or 3, when I think 3 is usually the age where a diagnosis of autism can be officially made. But what were you at 2 years and 11 months? Well, you were the same child, just weren't old enough to get a label. The second way of presentation of autism is acute regression. And a child who's typically in the second year, maybe speaking well, may have had a history of feeding difficulties or formula changes from feeding problems, recurrent otitis with antibiotic exposures, maybe a trigger of some sort, an infection, a fever, some inflammatory event, which might include an immunization, a long history of food and intestinal problems, maybe abnormal bowel movements, and then suddenly the child loses his speech, stops making eye contact, and goes completely to pieces. Next slide, please. This is, we're calling this grandma's sense, but this is the awareness by an experienced parent, often a grandmother, who says, there's something the matter with this baby. I wonder if he's deaf. And this is a very common thing at, say, 2 or 3 months. I think what is happening is the child doesn't have the micro twitches of a normal person, a neurotypical person, normal twitches of the facial muscles in response to speech rhythms. If those are missing, you may not be able to say what the problem is, but it looks like it's wrong. And that's where the grandmother might say the child is deaf, and there's another hearing test done after they say the newborn screen, and you find out the hearing apparatus seems to be working all right. Some children are too quiet or they cry too much. Some children are too bunched up or too floppy, and a variety of other subtle findings that are very hard to quantify, but it's useful to note them. Next slide, please. I'm going to tell you about my first patient. This was a young boy I met at about age 2.5. His mother brought him to me because she said, I think there's something wrong with his metabolism. He was clearly very autistic, and that had been recognized at the TEACH program at the University of North Carolina. He was flapping, he didn't talk, he was very frantic in the examining room, he made no eye contact at all. I didn't know then to ask, but I found out later he was having very abnormal bowel movements, which did not firm up until he was 8.5 years old. That's a long story about how he got there. We did our usual biochemical tests, amino acids and such, and didn't find anything noticeable. A year later, she called me and said, can I bring Devin to see you again? I said, sure. And he was much calmer. He was talking. He was making some eye contact. He was much less frantic. And I said, what have you done? And she said, he's off milk, he's off wheat, he's on nystatin because of Candida in his gut. He's on pancreatic enzyme supplements. He's on a variety of vitamin supplements. And I said, tell me more. Because from my work in inborn errors, I was quite aware if you eat the wrong thing and you've got a certain biochemical makeup, you could have very severe brain troubles. And it looked like he had severe brain troubles that were somehow related to what he was eating, what was going on in his gut, and they were reversible. So that was the first big clue to me that we needed to be paying close attention to these children. And I will turn it over to Kristi now to talk about Lady A.
Thank you, Dr. Kahler. Before I share this very personal story of Lady A and our family's journey, I just want to preface it by saying this is not our story and not her story alone, but a journey that has been guided by God. And the ultimate glory goes to him. I just am thankful each and every day for the divine appointments, information, and individuals like Dr. Kahler who were placed in our path, and for the empowerment that was given to my husband and I to trust our guts and to be assured that we knew our child best. It was first said to us in a GI appointment, well, maybe it's autism. We'll just need to wait and see if that's what it turns into. For my husband and I, we couldn't wait and see if that's what it turned into because our baby was in pain. Our Lady A started with symptoms of colic and irritability at about 4 to 6 weeks of age. She was what I would call an intermittent regressor, as Dr. Kahler shared on the presentation. She regressed with environmental triggers, inflammatory events, and food exposures. She would literally go mute for 2 weeks, and then just like a little computer would reboot and come back online and be interacting again. She was plagued by diarrhea, malabsorption, failure to thrive, and feeding difficulties for the first 2 to 3 years of life. And then about a year of age, autistic-like behaviors and self-injurious behaviors emerged after her 1-year well visit, cessation of breastfeeding, and introduction of cow's milk. At about 18 months of age, she tested positive for Clostridia difficile toxin A and B, and we attribute this to about 18 months of reflux meds that were being used to treat the colic. She also had severe neurological reactions. Again, these emerged around 18 months of age to household chemicals, perfumes, alcohol fumes, hand sanitizer, Windex. And it was then that we were led to our first neurological consult with a private practice neurologist who told us, I'll test her for every rare thing I learned about in medical school. And it was really the first blood testing that she had done in her 18 months of life. On those blood tests, we were found elevated lactic and pyruvic acids. He did this 3 different times, and they came back elevated all 3 times. Over the next couple years, we underwent a lot of metabolic testing, a lot of blood testing, urine testing, and some of the notable things looking back now, we can see where some red flags were low methionine, which was normal on newborn screening, low total homocysteine at 18 months, which was normal on newborn screening. And along our journey, we did also go down the genetic testing path with a whole exome sequencing that came back normal with no variants of unknown significance. Our path led us to a multi-specialty clinic in Arkansas with which Dr. Kahler was involved with. And it was during those visits that we found that she was insufficient in thiamine, and she was responsive to oral thiamine. This is a story, though, of hope, and that is why I'm here to share it with you all today. Today, Lady A is in junior high. She does not have an autism spectrum diagnosis, although we do believe in our hearts, had we not gone down the paths that we had gone down and made some of the changes for her body, that she would have that diagnosis. She has straight A's. She's gifted and talented student. She loves to ski. She loves to ice skate. She's a gymnast and a ventriloquist. And I know you all are probably wondering, well, how did biochemical genetics and metabolic genetics come into play in the story, and how did you go down that path? It was on a Google search many years ago that I came across this document by Dr. Martin Natovich who's now at Cleveland Clinic. And it was simply a post on a thread of children with special healthcare needs message board that said red flags requiring further scrutiny by a metabolic clinician. And after reading this list, I realized my sweet Lady A had about every single thing on this list. And that is what motivated us and encouraged us to go down the path to metabolic genetics. We have that as a handout, so you don't have to squint and see all the tiny words. So that leads me to give you this overview of the systems that we're going to talk about today, of the 3 systems that were involved in our journey, but they're involved in many children's journeys who have a diagnosis of autism: gastrointestinal system, the neurological system, and the immunological system. For us, this diagram shows it best. We had a precious child who had gastrointestinal, neurological, and immunological concerns. But when 3 or more systems are involved, we soon learned that could also mean that her mitochondria were not working well either. And that is what led us down this genetics, metabolic genetics, and clinical genetics path. With that, I'll turn it back over to Dr. Kahler to talk about some of the interplay between these 3 circles.
Yeah, thank you. My experience has been that about 3/4 or so of 80% of the children referred to me have got obvious food and intestinal problems. This is not everybody's experience. I think it's partly selection, by parents talking to each other. Some people say it's as low as 10%, other people say it's as high as 80%. I've certainly seen it written that diarrhea is common in autistic children. Well, it's not common to have diarrhea when you're 5. And it's certainly not normal to have diarrhea when you're 5 and can't get toiletry because your bowel movements aren't firm enough. Roughly 30% of the children that came to our clinic in Arkansas with Richard Fry in research studies of mitochondria in white blood cells, 30% of the children had impaired mitochondrial function. And it's not due to mitochondrial gene changes. It's due to something else that's messing up how they work, probably oxidative stress due to other causes. So here's the triangular array that I devised about almost 20 years ago now, showing how the brain and the gut and the immune system talk to each other. And there are arrows going each direction. These are bidirectional communication lines. At a talk I was at 15 years ago now, somebody said that the brain and the nervous system do the same thing. They both have to remember and they have to respond quickly. And the obvious conclusion was they have to be talking to each other. And there are now known to be a large number of ways with peptide hormones, with leukotrienes and other things from the lymphocytes, neurological, particularly through the vagus nerve, goes into the brain. The vagus nerve comes out of the brain, and it tells the gut a lot of things to do. The vagus sensory apparatus is plastered all over the abdominal lymph nodes. I think they're an auxiliary taste organ, so your brain is knowing what is going on in the gut, but it's not the same as taste on your tongue. The gut talks to the immune system. There's a lot of back and forth regulation of gut cells, regulation of what microbes live there or don't live there. The microbes are busy trying to make a home for themselves, and the gut has to decide, do you want them there or not? So there are a variety of things. And what is listed here as from the gut, the food and microbial products and neuropeptides, those include small fragments of gluten and casein that can bind to opiate receptors. And that, I think, is a very important part of this whole story, and why withdrawal of milk and wheat can be so beneficial for the children who are having a problem from it, like my friend Devin. Next slide, please. I think we cover this in other ways in a little more detail, but the high points are for these regressive children is an unusual or difficult infancy. Don't tolerate breastfeeding well. That was Lady A's trouble, I think. We've certainly had children who were responding to, I think, cow's milk protein being carried over to the baby through the mother. Multiple infections, otitis media is usually the one. Recurrent antibiotic exposure, which we worry influences gut microbial diversity. Some children have unexplained tachycardia, rapid heart rate when you don't expect it. And then the collapse with a febrile event that I mentioned earlier. Some of the parents will tell you, when my child gets sick and he doesn't eat for a few days, he does a lot better. He makes eye contact. That is a huge hint that something about eating is doing something to the child's brain that is reversible. Next slide, please. Generally, physical findings on children who have autism would be called non-syndromic. There's nothing specific about their physical features. The main thing that's been known for a long time is that a lot of our children have big heads. They're usually over the 50th centile, and the head growth starts in the second 6 months. We're not sure what it means, and it's not necessarily tied to any particular genetic component that might be part of autism. Next slide, please. One of the things, and this applies to Kristi's child, is that sensations are altered. They're either ignored or they're overwhelming. And this is similar to adults with the multiple chemical sensitivity program or problem. Is typical of migraine. Noises are loud, smells are intense, touch is painful. So a lot of what we see in the autism children who are so frantic is they are overwhelmed by whatever's going in. I use Walmart as a diagnostic challenge. Can your child go into Walmart? And the answer is no, or for 2 seconds, or so on. So When things get better, they can stand more of that kind of emotion. Dilated pupils is another interesting feature that we've noted in many of our children. I think it is probably too little parasympathetic activity rather than too much sympathetic activity. And a number of children get flushed cheeks, ears, episodes of that sometimes associated with certain foods, particularly salicylate dyes that are present in red and blue and yellow foods, and red fruit in particular. I also want to mention disturbed sleep. That makes everything worse. And that's a very common feature. And if you can get the sleep better, a lot of things get better at home. Next slide, please. Feeding problems in infancy, abnormal bowel movements, might be constipation due to slow transit, might be paradoxical diarrhea with a big wad of soft material in the right colon where a lot of the slowdown occurs. And the only thing that gets around is liquid. Some of our children are quite sensitive to milk and wheat. Coming off of milk will give you a response if there's going to be one within a few days. I usually try it for 3 weeks. Coming off of wheat can make a huge difference, but it can be very, very slow. Some of our children have responded to supplemental pancreatic enzymes. If your child's got abnormal bowel movements and you think this might be something that could be tried, it's easy to try. There are a number of pancreatic enzyme supplements available that might give you some information before the child gets to see the gastroenterologist. Next slide, please. This is my friend Devin. His mother said, I can't get his pediatrician to put him on a long dose, a running dose of an anti-Candida agent. And I said, why do you want that? And she said, because he's better on it. And this is when I was living in Australia. She was calling me by long distance. And I said, show me what he can do. And she said, well, here's 2 handwriting samples. The first one is off itraconazole, Sporanox. And the second one is after 5 days of being on it. She says his handwriting is better, his eye contact is better. And I said, you don't have to tell me anymore. This is totally convincing. His brain is working a whole lot better on the Sporanox. After he'd been on the diet a year, his mother said, I want to see how long does he need to be on it? I said, I don't have a clue. And at age 4, they gave him a challenge of pizza. It contained the gluten, the casein, the tomatoes, and the yeast that's in the dough. And he went from being a talkative, happy little boy to taking off his clothes and flapping around the kitchen with slurred speech in 20 minutes. 2 hours later, he was doubled over on the floor, clutching his stomach, wanting all the lights out and the curtains pulled. He was like that for 18 hours. And I asked him recently, what was that test like? You remembered? He said, of course I do. So he remembers everything. He said it was like there were knives cutting me from the inside. He had normal endoscopy, upper and lower, after that time and did not show anything, but he was clearly put into a great deal of pain. And if you were in pain and you can't talk, screaming and banging and pounding your head is what you're likely to do. Next slide, please. We mentioned the immune system, food intolerances, recurrent otitis, persistent rashes, particularly the perianal rash of Candida, is really common. It's not normal to have that for a long time. It's normal to have it transiently till you and your Candida get used to each other. We also have children who never get sick when everybody else in the house has got a cold. And we also have the children who get well transiently when they have a temperature of 104 from a fever. It does not happen in a hot tub or sauna, but a naturally occurring fever can make some children neurotypical transiently. All of these things we've talked about are hints that this is a reversible condition. It's more like a chronic intoxication than a permanent situation. Next slide, please. This is a diagram that was drawn by Sid Baker and John Pangborn at the first meeting of Defeat Autism Now in 1995. There were 32 people there. 6 of us were from mainstream medical schools. Half a dozen people were from the far fringes of medical practice. And I realized they were seeing the hardest patients, the ones that nobody else could figure out how to help. The point of this meeting was to see, could these 2 worlds learn to talk to each other, share a common language, and bridge the gap, as we call it. This diagram, which is in the handout, did not have the stars on it. This was their formulation of how things related to each other. Peptides, what the role of milk is, the intestinal malabsorption, all the rest of those things. The stars are reflecting published articles that have appeared since that time, confirming all of these suppositions and ideas about how these different systems might relate to each other. Next slide, please. So how does a biochemical geneticist get into this? Well, all behavior is biochemical and neurological in some way. Serotonin has always been known to have something to do with autism, just like it has something to do with depression and with migraine. And in all of these situations, there's too much serotonin in the platelets. And in the case of the SSRIs, we try to treat it that way. Some children with autism have responded to a low dose of SSRIs. Next slide, please. We should say something about genetics. I'm a geneticist. No one gene accounts for more than 1% of autism spectrum disorders. There certainly is family clustering of autism, but the recurrence risk is not the simple dominant recessive 50 or 25%. There are at least 200 genes that have been found to be implicated in autism in some way, but none of them guarantees a child will have autism. These are all risk factors, just like being a boy, which is the biggest single genetic risk factor for autism. Typically, geneticists will recommend doing a genetic panel, a sequencing of usually a couple of thousand genes involved in autism and brain dysfunction in general, or a chromosome microarray. You might find something interesting, might even find something that is very strongly associated with autism, but it's not going to tell you how to treat it any differently. So that's where the listening to the patient comes in, thinking about food, thinking about the gut, thinking about all the other parts of this syndrome that is more than a brain disorder. Next slide, please. PKU, I mentioned, PKU is 100% genetic. You must have mutations in both copies of the phenylalanine hydroxylase gene. It's 100% environmental. You must be getting too much phenylalanine in your diet to get damaged. So this is an example of a pure genetic disorder that's got a gorgeous environmental treatment. We think the same is true of many of our autism children. Next slide, please. Who helps out? I think the next slide will show us what we were doing in our clinic in Arkansas with Richard Fry and George Fuchs. This is also in the handout. You can see that all of us had some kind of role to play, and a nutritionist who's specialized in restricted diets and how do you nourish people properly and so on. So these are all things that are useful about a multidisciplinary clinic if you get all these people together working on the same children. Next slide, please. Please ignore that phone ringing.
With that, I'll take it from here, Dr. Kahler. So the when do I refer to a specialist and when do I refer to genetics? We're going to refer to this slide, our red flags for referral of a child with autism, to genetics or a specialist team. And we say a specialist team here, as Dr. Kahler shared. In my family's journey, a multi-specialty clinic was very helpful to have everybody communicating and on the same page. But these are just a few of the red flags. Regression, which can include loss of speech or change in motor skills, that positive family history for autism or other related neurodevelopmental disorders. And then we have the three categories, the neurological, immunological, and gastrointestinal dysfunction. And those might not need a geneticist first. They may need that specialty area as a referral first. So our recommendation here is to talk with your local team, the specialists that you refer to, and ask where they can help you and families if you are a primary care provider or pediatrician in treating these comorbidities of autism and what their comfort level is with certain symptoms. The next question is how can you support this family in your primary care office, and what are some things that you can do to help this family immediately? With this, I asked the question, or this was asked of our family, and it's something that I ask other families as well. Does your child have good days or bad days? For us and Lady A, there were many good days where we didn't see pain. We didn't see any of these symptoms. And then there were some really bad days. And so we thought in our heads that if we could figure out what made a good day versus a bad day, that we could replicate the good days and make more of those and make the environment, her environment, fit that so that she would be out of pain. So what did we do? We did a trial. My background's in chemistry, and so we tested. So trial here is a mnemonic just to think through with the families that you're working with. T is for test, measure their biology, use blood testing, urine testing, other types of testing that might give you some clues as to what's going on in the biology and the biochemistry of that child. R and I stand for remove inflamers. Is there a fire that needs to be put out? In our case, we were at a point where we'd rather take something out of her environment rather than introduce something to it, because she was such a hypersensitive reactor. And so we knew that there must already be some things already in there that were inflaming her that we needed to remove. A is for accumulate data. Empower families to gather and share data with their team. I, thinking as a chemist, wanted to do one thing at a time, so I knew if it worked or not. But when I talk with families and other moms and they get overwhelmed by the idea of data, I say it can be literally as easy as putting a smiley face or a sad face on a calendar that sits beside your bedstand at night. Did your child have a good day or a bad day? And then last, the L for trial, look and listen for clues. What is the next step, the next tweak, the next trial that you can do? And then repeat. So we have some ideas on these slides just from my own journey of things that you might want to test for. For our family, those first 5 were very helpful, as something as simple as a CBC and a complete metabolic panel, amino acids and acyl carnitines, and total homocysteine, as I mentioned. Some of the other things down below do rule out some other metabolic disorders, rule in or rule out other metabolic disorders. And then this slide gives some ideas for removing inflamers. As we've talked about, removing milk and dairy, wheat and gluten. Also, I want to add here, soy was a big trigger for my daughter. And then we also found her to be a salicylate reactor. And so certain diets out there look at different things that might be inflammatory for children. Again, not all these diets will work for all children, but that's why you have to try, do a trial and try and see. We also reduced chemical exposure in our home environment. There are some things you can add as well that might be very simple fixes, Epsom salt baths, fish oils. As I mentioned, our daughter responded to oral thiamine and probiotics. But again, you want to look for clues that might give you indications that these might help. And last but not least, look and listen for clues. This quote from a consensus article in 2010 really stood out to me when I came across it, because it really summed up what my husband and I experienced with our daughter. Care providers should be aware that problem behaviors in patients with ASD may be the primary or sole symptom of the underlying medical condition, including some gastrointestinal disorders. And that's what we saw. We saw the problem behavior, the head banging, the autistic-like behaviors as the sole symptom of pain. And so if you see pounding heads, consider headache, abdominal pain, screaming outbursts, think about reflux, pounding or clutching of the abdomen, consider pain and cramps, and stimming, flapping, humming, vocal tics, consider those as self-calming behaviors. And with that, we're at our last slide with our contact information, and we are happy to provide more information if you have questions. And with that, we'll pause and let Kim let us know if we have some questions from the audience.
Great. Thank you, Dr. Kahler. Thank you, Kristi. So if you do have any questions, feel free to enter those in the Q&A or the chat. So we do have a couple questions. The first one, getting right to a hot topic. So you mentioned immunization as a trigger for autism. My mother is a neuropsychologist who has had patients with sudden regression and development of autistic symptoms shortly after a vaccine. So many vehemently, sorry, I can't say that very well. Many people deny this link. What is your opinion? And then the second part of this question is, maybe vaccines could cause the regression kind rather than the kind that seem to be present all along. Thoughts on that?
Controversial, to say the least. I have certainly seen this story many times, and we have videos of children who are walking and talking and looking great at 16 months, who look terrible at 18 months. That's when the regression autism occurs. I think there are a number of different triggers that might be there that trigger inflammation. Inflammation is the point of an immunization. So certainly not the only possible trigger, but I think it's one of them. We certainly know of children who've had a second regression after booster immunizations with the MMR, particularly at age 4 or 5. So if you just look at large populations, you won't find the signal. If you look at individual patients, you will. And I think it's like looking through the wrong end of the telescope. As a group, you can see that immunizations do a wonderful job and are safe for nearly everybody. But there are going to be some where it's not, and you need to pay attention to those patients. Just say, okay, I'm concerned about this in your child. Let's go easy on the next ones. And if people ask me about it, I'll say, one at a time, never while sick. Those are both in the package inserts. And if there's any, and do the most important ones first for the parents who are really hesitant. The most important ones include the important ones. There are other ones that are less important, and we don't need to rush into them if people are being worried about it. Say, no, we don't need to give hepatitis B on day 1. Your child's not going to be exposed to that for a while. Let's not discuss that one. Let's discuss polio vaccine. Nobody's ever said they had a hard problem with polio vaccine since we went back to the killed virus. So, there's nuances to all of this. The second thing I did want to go back to something else that Kristi said, things you can do. One of the things that has been most useful that we didn't mention at all is methylcobalamin, a form of B12 given by injection. We're not quite sure how it works, but it certainly reduces oxidative stress in the children who have that. And it typically improves speech and improves eye contact. Those have all been published by work by Richard Fry and others. So we didn't put that on a list of things to know about. I'm not suggesting that the pediatrician needs to do them, but you should be aware of these things and you may be asked.
Great, thank you.
Got more questions?
Another question, another question. How old would be considered too late to make a referral and to make any difference in the improvement of the comorbidities of a child diagnosed with autism?
Never too late. Donna Williams started getting better at age 25. I had a starter patient, not a starter patient, I had a patient who at age 15 came to me in Australia from the other side of the country, came to see he was having intestinal troubles. He was quite violent, and we wanted to take him off milk, take him off wheat, and put him on antifungal medications or anti-Candida medications. And I called his mother up a month later, said, what happened? So we were going to do things one at a time. And she said, well, we couldn't stand the wait. We did everything at once. I said, what happened? She said, well, his brother and sister used to say 95% of being with Justin, he was a pain. Now 95% of the time, he's just great to be around. So it's never too late. I think this is a long-term intoxication story rather than a permanent injury to the brain. So Donna Williams, who's written about this, she must be, I saw her at age 40, and that was 15 years ago. So she's in her 50s, but she started getting better in her 20s.
Great. Okay, one more question. So MTHFR gene or mutation. Some parents are convinced, oh, hold on, my screen moved. Some parents are convinced that the MTHFR variant contributes to symptoms in their children or themselves. So folate versus folic acid in that child's pregnancy and other dietary modifications. What is your response, or what is your response to this question?
The common variants of MTHFR are really common. They probably cause no trouble at all if nothing else is going on. The common one is a temperature labile mutant, so the enzyme doesn't work as well when you have a fever. Well, that might be interesting, but if you want to get more folate into somebody because you think you want to do it, you can use just straight folate, you can use folic acid, You can use methylfolate. The form that gets into the brain best is folinic acid. It's more expensive, but that's the one that gets into the brain. There's a lot still to be learned about what this is doing. So I would say it's probably by itself, it's not a troublemaker, but maybe in combination with other things, supplying folate can be helpful. And when we use folinic acid, we're using 1 or 2 milligrams per kilo per day, because we really want to get a lot in because we assume it's not being recycled properly. But that's for biochemical people like me to think about. But you don't blow it off. If people are concerned about it, address their concerns.
Great. Well, that was a wonderful presentation. Thank you very much, Kristi and Dr. Kahler. That wraps up this session.